Okay, with that said, I want to move on to our next speaker, Dr. Ali Farooqui, who is joining us from Louisville, Kentucky, and he is the managing partner for integrative psychiatry there. Dr. Farooqui is a pioneer in the field of interventional mental health for multiple types of disorders, and he's known for bridging the gap between traditional therapy and advanced brain science, which is why he's here today. He's going to be discussing his clinical experience with the PRISM system. It's a groundbreaking FDA cleared medical device developed by Gray Matters Health. And PRISM uses advanced EEG, fMRI neurofeedback to help patients see and regulate their own brain's trauma response in real time. We've had a lot of questions in here about neurofeedback, and I've been suggesting you hold off for this session because I think Dr. Farooqui, is going to be able to speak to not only just the PRISM system, but to neurofeedback in general. So please do put your questions in the Q&A for him on that. He is going to talk to us about PRISM and its use today, specifically for PTSD, that's post-traumatic stress disorder, and other complex mental health conditions. So, Dr. Farooqui, I see you there. Thank you so much for joining us today.
Thank you for having me.
Yeah, great.
Yeah.
Well, I know we have a couple of slides that we're just going to walk through as we go through some questions here. So, I kind of wanted to start us off by a little bit of your background. You started off in neurological surgery before moving into psychiatry. And most people see those really as two different worlds, the physical brain versus the emotional mind. What was the moment or the specific patient that made you realize that surgery wasn't really the answer and you needed to understand the emotional mind in conjunction with that?
Yeah, great question. First of all, thank you for inviting me. It's a pleasure to be here. I really enjoyed the last conversation as well with your last speaker. So we've had a lot of experience with ketamine as well in our practice. But yeah, so I did neurosurgery right after residency, and there really wasn't any specific moments. I'm a neuroscientist, so I went into medical school with the intention of working within the neurosciences. And, surgery is pretty cool. And I enjoyed it, and I enjoyed the patients and the procedures. It's the facets of treating people with neurological illnesses are so broad. It's really the last frontier, kind of like Star Trek. It's the last frontier of medicine, and it's really complex. The brain is like a house with old wiring, and you don't really know where the circuit breakers are or where they go to. And so when I left neurosurgery and I went into the finance sector and the private equity sector for a little while, but then decided to come back to medicine because I love it. I like treating patients. Psychiatry made sense. It made sense to practice here in that way. Now, psychiatry and surgery are actually very similar because in a lot of different specialties, the way that you treat a person, whether they're in Australia or China or Africa or the United States, is the same. So, for example, if you have a heart attack, you're pretty much going to get an algorithmic, straightforward plan of care no matter where you are in the world. But psychiatry and surgery are the only two fields where style actually matters. So the way that you treat a patient, your own individual style, your approach, it changes outcomes. And so it's a really cool mesh between the two fields.
Awesome. Yeah, so you've worn a lot of different hats, really guiding technology development as part of a venture capital, as well as leadership roles in scientific and medical organizations, and then clinical practice. Is there a common thread of optimism or frustration really with the future of neurological care that connects all of these roles?
Yeah, so the optimism is actually about what you are doing. So, we're transitioning away in psychiatric and mental health care from symptom-based treatment, meaning, if you're sleepy, if you can't sleep, you take this. If you're anxious, you take that. If you're depressed, you take that. We're moving away from that more towards brain-based care, which is not to say there's not an interplay, right? So your experience in the world matters, but the hardwiring matters too, and how your brain actually is biologically and then how it's connected. We're starting to understand that more. And so the treatments are really moving in that direction. And you can see that in terms of where the development is coming from and what the conversations are. And for you having platforms like this for folks to discuss these things and bring more awareness to them. In the scientific world, it's also happening, but it's not to the point where the conversations are reaching, coffee tables or dinner tables yet. So, but they're progressing in that direction for sure.
Yeah, we've had, well, you heard Dr. Boyette's. The other speaker we had that really talked about that was Dr. Brennan Spiegel on virtual reality and how the mind-body connection is so powerful and how the tool of virtual reality really plays on all of those individual components, not treating them separately, but bringing them all together. And the results that he shared with us were just mind-blowing. I left that conversation yesterday wanting to go specifically to the VR conference so I could learn about how they're integrating that so well into that technology. And it was treating so many different types of issues. We were talking specifically about pain yesterday, but he looks at the emotional issues as well as physical, like from burns were a big piece of that. But he also talked about the meditative piece of that and overall mood regulation in general. But it was the components that put it together, and even stimulating out of body experiences for people who are using that technology. So I think that you're right. That does seem like the future and where it's going. What do you think we can do to help move that along further in the scientific world? Is there something that's missing out there that we being the industry as a whole can do?
Yeah, I mean, you're doing it. So
Okay.
this is this is how it starts. I mean, there's always going to be a lag in medicine. I mean, we know that it's been always the case, and that's actually not a bad thing. The lag is there because of safety. You want to make treatments that are novel accessible to people, but you want to make sure that they are safe before we do that. And so we have a lot of treatments that come out that show promise initially, but then they don't actually make it into the public sphere or the public knowledge base because they were found to not be safe enough to justify use in a wide scale fashion. So that's really the purpose of the lag. But I love what you're doing with by allowing folks to just be educated on how the field is developing and where the world is headed towards in terms of treating brain disorders.
Dr. Farooqui, I would like, this is a little off topic from what we had planned to discuss, but I think it's relevant for this conversation and the audience based on the types of questions we've been getting in our chat room, which is the value of evidentiary support versus clinical trials as you, an individual, are trying to determine whether some of these new technologies that are out there could be a fit for you. And there seems to be a lot of individuals in this field who are maybe just getting started that are going down the evidentiary path or don't have the backing to go and move that to clinical trials. Can you share your perspective since you're at this point where you're bridging the technology development and the research to that? I would love to get your perspective for our audience on how to evaluate that for yourself.
It's if I understand correctly, I think you're asking clinical, do you rely on the clinical trials? You rely on the clinical experience? Help me understand the
Yeah,
question.
Yeah, let me clarify. How do you, as an individual, take a look at the evidentiary support that is there if they don't have the third party randomized clinical trials, which are the gold standard, right? But if a new technology or a new therapy or an innovation has only evidentiary support and maybe some small trials that wouldn't meet sort of the randomized gold standard test. That's the
Yes.
question.
So, no, that's a great. So, the purpose of a clinical trial really is to determine if the therapy is beneficial independently. And so that's what you do. That's why there's a control group. You try to control for all variables, and just introduce one thing. But if you look across the board in terms of what happens with individuals after in the real world, which is why we have real world outcome studies, is because the trial population, the trial results are not equivalent to what happens in the real world because you don't have control of all independent variables because people are people and lives are lives, and you can't really silo them and isolate folks for the rest of their lives so just so something can work in the way that it was studied. And so the clinical trials tell us in the how a specific treatment works and what is the effect of that treatment alone. Now, in the real world, things are different. So, are there potential therapies that failed in a clinical trial setting, but if they were to be used in conjunction, they would have been supremely successful? Possibly, but that's not the way that, unfortunately, some of the trials are done. There's a significant cost problem as well in terms of clinical trials. They're not cheap to do. So a lot of companies that support, whether it's pharmacotherapies, medications, for example, or technologies, they really might have funding for one trial. And so if they learn lessons during that trial about, oh man, I wish we did this because it would have been really nice if it was really successful, they might not be able to actually execute that idea. And so they'll publish it, they'll write about it, they'll discuss it in meetings like this, but they might not be able to actually utilize it. And so what ends up happening is those technologies or those treatments can end up in clinics and used, and evidence can gather around that. And the prime example of that is actually what your previous speaker talked about is ketamine. Ketamine, one of the reasons that there's no clinical trials for ketamine, it's not FDA approved, is because it's generic. There's not a return on investment for a lot of companies to actually get an FDA approval for it. And so because of that lack of incentive, that's what happens. Yeah.
Yeah, thank you for that. That was very helpful for me and my understanding as well and I hope the audience got something out of that. So, um, forgive my personal interest there for just a second. Okay, so back to the PRISM system. So, most of us use the word trauma quite loosely, actually, and in conversation, as I was traumatized about this, it was such a traumatic event. But inside the brain, PTSD it's not just a feeling, it's a physical state of emergency that has failed to turn off. So can you walk us through the biology of that? When a person is triggered, what is actually happening in the brain, and how does a single moment in time physically rewire the brain to stay in a state of survival for years after the threat has gone?
Yeah, great. I mean, great question. And I really like the fact that we're setting the scene before we discuss the therapy and the technology. And so, I think what we're talking about in terms of PTSD is very different than a memory. So, and it's very different from an emotional experience. So you can experience something that is distressing, and you might colloquially use the vocabulary of, "Man, I have PTSD from this," or "Oh gosh, that was so traumatizing to me." But the reality is that that is not the disorder of post-traumatic stress. So that is a disorder. In the same way that grief and sadness is different from depression, in the same way that apprehension And nervousness is different from an anxiety disorder in the same way that having mood fluctuations is very different from bipolar illness. So, we can use those terms a lot of times, but they mean different things. And to people in professionals in the community, in the treatment community, and the clinicians, they are very different things. Before talking about what is PTSD, I think it's important to identify where is PTSD. And the amygdala, which you'll hear me talk a lot about, especially with patients and in conversations such as this, the amygdala is really the fight or flight response. Okay, so when you're feeling fight or flighty, that's your amygdala activating. It's telling you that there's threat. It's telling you that there is danger. And it tells the rest of your body and your brain what you need to do to be safe. Okay? That is what the amygdala does. It is very rudimentary. It's lizard brain, quote unquote, lizard brain, because we need the amygdala to survive. We need the amygdala to be able to get us to safety when we are in an unsafe environment. So we don't have ways to specifically directly target the amygdala, partly because it is a necessary survival part structure of the brain. So you don't want to shut it off. You want it to be regulated. And when it becomes unregulated in a hyperactive way, that's when you get some of the symptoms that are associated with rumination, with flashbacks, and with the PTSD type of picture that you described. But now, specifically, the amygdala is not independent, though. It is wired and interconnected with other systems in the brain. And so I really like to think of the brain as a house with wiring, like I mentioned before. And you have circuit breakers that connect to wires in different rooms. And if it's an older house, and maybe some folks live in an older house, I do, or and so you might not know which circuit breaker goes to what room, and there might be some crisscrossing wires. And so what you see is dysregulation in one system can actually lead to multiple different problems. And some folks might wonder, hey, is this why I have 5 different diagnoses? Potentially, because if your emotional regulation system, which includes the amygdala, it's not exclusive to the amygdala, it's not the only part in emotional regulation, but it's one of them. And if you have a problem there, then anxiety, depression, PTSD, a lot of those symptoms can come into play. So diagnostically, someone might say that you have 5 different diagnoses, but in reality, there might just be one problem that needs to be addressed. Okay, and that's important because of the way that we naturally how our brain manages itself, how we regulate ourselves. So this is a little bit of a confusing slide, but I'll walk you guys through it. So the hippocampus, which is in the blue there, that's a blue cogwheel, that is your memory formation. That's consolidation. That's your storage. Okay. Your amygdala is the fear center. Your prefrontal cortex, and this might have come up before, your prefrontal cortex is your executive functioning. It's your processing. It's your control, your brain control over a situation. So if you come across a situation where maybe you were involved in a car accident, or there was something going on where people were in danger, your life was in danger, or your loved one's life was in danger, then you just jump into action. You don't even think, you just do the things that you need to do to get to safety. That's your prefrontal cortex taking over. And that's where you get stories like, oh man, my leg was broken, but my kid was in the car. And so I got my kid out of the car, got them to safety. And that's when I noticed that that my leg was broken and I had significant pain and I passed out. Well, that's because your prefrontal cortex has taken over, suppressed everything else so you don't feel anything, and you are just acting. and your prefrontal cortex has taken over. When you experience a trauma that really elevates the amygdala, and it ends up suppressing the prefrontal cortex, and so your thinking, the cognitive control of your emotions is blunted, and the emotional arousal, the amygdala arousal takes over. When that gets encoded and stored as a memory, then essentially what you have is a PTSD type of a picture where your brain is telling you, hey, if I see a fluffy dog, that's a bear that once attacked you. You got to run away. You got to get to safety now. And so your amygdala stays primed, ready to jump into action to get you to safety. Your brain thinks that what happened then is happening now. And that's essentially the picture of PTSD that we see, that we treat.
This slide is that's a phenomenal slide actually to help you understand that process and the difference between the two. So I may ask to borrow this. That's fantastic. You brought up in the example that you used there you and the role that emotion played actually in both of those scenarios, right? Is In both of those, though, safety was a primary function, right? So I've got to get out of the car. I've got to go get my baby. I've got to make sure that I move. I'm not going to be worried about my physical. But in the other scenario, emotion is also a big factor there. So how do you explain the role of emotion then in those two different scenarios? Are they already out of balance when you react in that way differently, or is there a underlying issue with emotion that is driving the reaction in the different second scenario?
No, I mean the context matters a lot. So,
Okay.
like if you, and I could go into an hour-long lecture on just this,
I'm
or hour-long conversation on just this alone, but the context matters a lot. So, suppose that a bear, you're walking in the park, a bear jumps out, and you got your kids with you. You jump in the car and you drive away. How are you going to process that? Well, if your kids were sick last week and really vulnerable and they're really weak, and you took them to the park so they can enjoy themselves, then that scenario is the context of that scenario will lead for an encoding of a I need to protect my kids at all costs type of a encoding. Okay. Now, suppose you took your kids to the park because they won a football game or a wrestling championship or something like that. Then the context is not that of your kids being vulnerable. It's of them being, you know, quote unquote, strong and healthy. And you might not encode that in a traumatic way, because the
Mhm.
context matters significantly.
Okay.
Usually, so this is a very simplified way of understanding the disorder in terms of when we treat folks. But in terms of how PTSD is formed, that's a complete separate conversation. This slide is not enough to be able to explain that.
Okay. All right. Let me come back up and get out of the details there. All right. So for decades, the gold standard for PTSD has been exposure therapy. So walking through that nightmare and reliving it over and over again, which is something I know is the beauty of the PRISM system. So, from your perspective, does that approach of immersion or re-exposure therapy still work, or are we just re-traumatizing them because we just didn't have better tools until now?
So, great question. So, trauma-focused therapies is not just exposure. So, there's cognitive behavior therapy, stress resilience building. So, there's other things that we can do to treat PTSD. An astute clinician can help navigate through what is appropriate for someone. Because exposure therapy might not be appropriate for somebody, but it might be appropriate for someone else. And so you really have to work with your clinician, with your doctor, advanced APP or therapist to really figure out which direction am I going to go in. What therapy does is it improves the green cogwheel in the slides. So what it does is it helps make the prefrontal cortex, the control, the cognitive control, it improves that. Okay. Whether that's from you recognizing that, okay, what happened then is not happening now, whether that's by developing the accessory muscles of your emotional regulation. But essentially that's what it's doing. It's by contrast, the amygdala the red cogwheel will shrink, but that's because the green cogwheel is going to get bigger, right? And even with medications, so when I prescribe medications for PTSD, suppose I prescribe an SSRI or SNRI or something like that, what I'm essentially doing is I'm giving the brain the substrates for resilience. So I'm not necessarily reducing the amygdala hyperactivity directly. There are medications that do that too, but not well, because I really need the prefrontal cortex to blossom in order to treat PTSD in the traditional way. And that's the beauty of PRISM, is because what PRISM does is that you can work on your prefrontal cortex, you can work on therapy, you can do all of those things. But what PRISM's trying to do is teach the brain to remember and go back to having a more appropriately sized amygdala. By size, of course, I don't mean actual size, but I'm saying like in terms of the activity. It actually teaches the brain to reduce the amygdala activity. And that's a very interesting treatment because it's very different than the traditional methodologies of treating PTSD. And the added beauty of the PRISM system is that, there are other treatments that say that, yeah, we can reduce the amygdala, but with PRISM, you know that you're doing it because we have validated measures and validated tools that we can actually see the activity go down. We can measure how much it goes down. So it's not a kind of a nebulous shot in the dark, whether it's working or not working. We know that it is when it is.
Yeah, so the PRISM system is helping to bring everything back into balance, this neurofeedback, bringing it back into balance. You're doing it, you're controlling it. And so therefore you don't have to go through then reliving the trauma, which from an emotional standpoint, I would think would even help make that quicker if I understand how this works well. So it should accelerate the recovery process overall.
It treats. I don't want to say that it's going to make it quicker because it might for some individuals, but for other individuals it'll take the time that it takes. 'Cause everyone's brains are different, it's a more direct treatment. But I want to address how Prism does that, and so. It's when your amygdala is activated, your brain will give it blood flow. So it becomes more active. Just like when you work out a muscle and it becomes active, your muscle swells up, blood flow goes to that muscle. If you're doing curls on a bicep, you can see your veins popping out and all that stuff. And so the same thing happens in the brain. Your brain only gets what the blood that it gets. It's a matter of where the blood goes and how it uses it. So, a certain percentage, so 20% of all the blood that leaves your heart goes to your brain. It doesn't go up, it doesn't go down. It's always 20%. But where the brain is active will change what is happening to you. So we can measure that. We can measure the function of the brain and how much it's metabolizing by something called the functional MRI or fMRI, which is very cost prohibitive. It's very expensive. So it's used in research, and folks are trying to bring it more into the clinical side where it can be used more directly for patients' treatments, but it's not there yet. It is a significant cost prohibition to it. Now, an EEG is a brainwave test. And EEGs are excellent for looking at seizures. It's excellent for looking at encephalopathy. If you're in the ICU or in the hospital setting, it's really good if you're doing surgeries to make sure that you're not that you're in the right areas. But in EEG, you put leads and they measure brain waves from different parts of your brain, and we still rely for the most part on people reading the EEGs. Now, what the researchers with gray matters, what they did is they correlated changes in amygdala activity to EEG changes and validated against the two. So, and you couldn't do that with the naked eye. So you have to use machine learning and machine models to do it. So you looked at changes in the EEG that might be imperceptible to you and I, but a computer system can pick that up and correlated that with up and down amygdala activity. And they were able to do that to essentially create a biomarker for your amygdala activity. So, meaning that I don't need a functional MRI. If I am using PRISM's technology, then I wear a cap like the one on my slide here. It has 9 leads, and it will tell me what my amygdala is doing using a validated, proven, machine-backed algorithm to figure out, okay, based on these EEG changes, this is what the person's fMRI is doing. And that's been validated. That's what's happening. So now we can use that to treat people. And that's what PRISM essentially does, is it uses that technology, that biomarker, the EEG fMRI biomarker technology, it uses that to drive treatment. And the way that it drives treatment is essentially what you see here. So you see that there's a hospital waiting room. The patient wears the cap, it reads their brain waves, and then on a computer screen, they see this hospital waiting room. And the
I understand.
go back here. So I thought that we didn't have.
I understand.
So essentially, so you saw that I'm going to go back here to the slide here. So you saw that the hospital waiting room, it has people walking around. It has people. It's kind of loud, and the patient's sitting there. The patient employs a mental strategy, which is a emotional feeling, a memory, a scenario that makes them feel calm and feel safe. And as their brain becomes starts feeling safe, their amygdala goes down, and the computer system responds to the changes in their brain waves, and the waiting room gets quieter. People start sitting down. At one point, there's a person coughing in the waiting room. That goes away. And so you can visually see your amygdala response decreasing. A lot of traditional therapies, they involve building on a mental strategy. So if you do visualization, for example, you build on it and really strengthen that activity, that place where you feel calm. What PRISM wants is and with the treatment with PRISM, you actually deconstruct it. It's kind of like riding a bicycle. Once you can't read how to ride a bicycle on a piece of paper and then go out and ride a bicycle. No, you have to feel the balance, right? And our chief medical officer gave me this example, and it's excellent, which is once you know the feeling of balance, you don't have to learn how to ride a bicycle again because you know the feeling of balance now. And so what PRISM tries to do in the context of PTSD is feel what it's like to not have a hyperactive amygdala. So you deconstruct that memory, that scenario, and you break it down to just the feeling of not being aroused. And you do that over 15 sessions, 4 45 minutes each. You can trial different mental strategies in the first few sessions to see what works, and you'll know what works because we can actually measure that with the biomarker. It's not a guessing game anymore. So you can actually do 5 different strategies on day 1, see which one reduce the amygdala activity, reduce your fear response, reduce your arousal the most, and then work on the top 2 and then continue doing that. Continue breaking it down into the feeling of not being aroused from a fear perspective. And that's how it works. So it has nothing to do with the trauma. You can have whatever trauma that you have. It's totally irrelevant because we know what the trauma did. And what the trauma did is it dysregulated your amygdala and made it hyperactive. So what we're going to do is reduce the amygdala activity independent of what your trauma is, independent of what else is going on, independent of what other medications you're taking, because the other medications don't work on this. They can complement the treatment, but they don't conflict with the PRISM treatment.
Yeah, so back to kind of the context question we were talking about earlier, right? This takes the need for context out of it, quite frankly. Yeah. Just
Yeah.
it removes that piece of it. And how do you combine this though with talk therapy at all, or is it just on its own?
It was studied.
Monotherapy.
It was studied in that way, but you can combine it because there's no conflict there.
Yeah.
So absolutely, because general traditional psychotherapy is working on improving your cognitive control, your regulation from a different angle. PRISM is attacking the problem from a different angle, from a new angle, an angle that people couldn't do before because we didn't have enough information, enough data to know that it was successful. We do now. And so we can combine this with traditional therapy. We can combine this with medications, or we can use it independently. And that actually brings to our next point, which is that if you combine PRISM with, as you can see the bottom slide there, if you combine PRISM with standard of care, or you do just standard of care, then it's that learning balance on riding a bicycle. Not only do you have a more percentage of individuals that get better at the end of the trial, which is 2 months, but because they learned the balance, their continued improvement without any clinical interventions is greater. Because it's not that they learn the control. So if you think about it, control means that I'm trying to suppress the amygdala activity. But if I know how to bring my amygdala activity down, if I know how to bring that fear system down, then that's independent of any other interventions. That could be enough. Like, you don't need your parent or your older sibling to grab onto the back of your bicycle once you learn to ride it. You know what balance is like. You might be wobbly the next time you get on a bike 10 years later, but you don't need someone to hold on to you anymore. You don't need training wheels anymore, right? And so it's the same concept, is that once your brain learns how to bring the amygdala down, then you'll see continued improvement. At least in the trials, and that's what you see is continued improvement.
And I would say, just to continue with your analogy, right? So once you learn to ride the bike, it makes it easier to ride the scooter, and then you can branch out to inline skating, and you've just got your balance, right? And so it would seem to me that the use of this system has much greater reach beyond trauma.
Absolutely,
Yeah.
and if the slide that I had before about what the amygdala-based system, the emotional regulation system, the different disorders that it can touch, includes substance use disorders. It includes depression. In fact, PRISM has a biomarker for reward and pleasure as well. So it's not
Mm.
FDA approved yet, but that's, going to hopefully be happening in the future. But that is also available, and it's a different biomarker, and it's a different mental strategy. And so in that, so in the PTSD, you have your brain go to a place of calm and safety, and you deconstruct that into the feeling of calm and safety by looking at what the waiting room is doing in the on the computer screen in front of you. In the depression treatment protocol, it's different brain, it's the same cap, but the machine is using a different algorithm to look at your reward, your some of the dopaminergic parts of your brain. It's looking at that, and the strategy is around activating and reward and positive, feelings of being happy and content, and the screen is not a hospital system. It's actually a dog, and that the more your biomarker goes up, because you want your reward system to be upregulated when you're depressed, then the more excited the dog becomes. So it's actually kind of cute. But there's applications, and as this technology starts to develop, there'll be potentially even more.
Yeah. So, Dr. Fergie, how does this differ from traditional neurofeedback? People want to know. It's like they've heard of neurofeedback, but this is different in a couple of ways. Can you explain that?
It's a more precise and direct form of neurofeedback. So if you think of like neurofeedback and biofeedback, there's a lot of different varieties of it. EMDR to a certain degree is kind of a biofeedback related. If you do EEG based treatments, that's biofeedback related. And technically biofeedback, if you treat someone's EKG, that's technically biofeedback too, because you have a biological tool that you are then utilizing to drive and guide your treatment. So, but what PRISM does is it gives you the reliability that otherwise wasn't there. It gives you the predictability that otherwise wasn't there. So for example, I can sit down with my PRISM cap on, and I've done it in my office, so I've so we let folks do a demo to trial it out before they engage in treatments with this. But it's you can try different mental strategies, and it might be that walking on the beach works for some really well for someone, but it might be that thinking of their childhood pet or their grandpa's house or something like that works really well for somebody else. But you wouldn't really know that unless you had a reliable biomarker for it, right? So a lot of patients might go to what's convenient, or they might go to the example that people use. So, I made what I used to do is give people the example of a beach, right? And but that might not be the best strategy for the individual, but they would just default to that because that's what I told them about, or that's what we practice. And when we do cognitive behavior therapy and we do visualization exercises with that as a way to, same thing, to exert cognitive control, a lot of times the scenario can be influenced by the person that you're with. Some people like forests, some people like beaches. But what PRISM does is it allows for you to figure out what your brain responds to the most in the way that you want to respond to it. Because when you are doing the PTSD treatment, the system is not measuring your sense of happiness. It's measuring the amygdala. It's measuring fear and arousal. And so it could be that the thing that worked for you the most, petting your family dog, it made you happy, but it didn't downregulate your amygdala. So you might have like worked on that in therapy for years. But when you sit in front of PRISM, that might not work as well anymore. Because sure, that is beneficial for cognitive control. But what we want to do is actually address the abnormality in PTSD, which is a hyperactive amygdala. And that might require a different strategy.
Got it. Yeah. So it's like almost everything that we've learned about in neuroplasticity and all of these technologies and interventions. It's the precision that enables it to be effective.
100%.
Yeah.
Yeah. Yeah.
Yeah. So, can you share with us any examples of patients that have benefited from this? Do you have some case studies, and maybe are there certain traumas that are not treatable with this technology?
Uh, I'll answer the second part of the question first. Are there certain traumas that are
Okay.
not treatable? Not that we know of, because it's kind of like if I have high cholesterol, I can eat a cheeseburger from McDonald's, I can eat a cheeseburger from home, and it's gonna, so it's not gonna the impact of the cheeseburger on my arteries is gonna be the same. And so it doesn't matter what the trauma is, the impact that it's having on the brain is the same. It's that arousal, it's a fight or flight response type of being dysregulated. So all that is and that is what PRISM addressed. So it doesn't address the trauma; it addresses what the trauma does to you. And that's, I
Got it.
think, a very important differentiator. And it's actually empowering because for folks, like, it doesn't matter how bad or not bad your trauma is. Believe it or not, a lot of patients have a lot of shame because they think that they should not have PTSD over how minuscule they perceive the trauma to be for them compared to other people that they might know. But it doesn't matter. What matters is what it did to you and what it did to your brain, and how can we address that and how can we treat you. That's what we care about. And that's what this allows for us. The PRISM system allows for us to do that. In terms of improvement, it's really elegant and beautiful in its subtlety, but also palpably profound. So, because when you, if I always tell people, if a treatment's working right, then it feels natural, right? So, like, if you're, and just like the example of riding a bicycle, once you know how to ride a bicycle, it's natural. You don't have to think about it anymore. And so the response that we get and the feedback that we get from patients is that it's natural. It's like a dimmer switch changing over time where you don't even perceive that it's happening, but it is happening. And if they look back to end of treatment versus when they first started, they can confidently state that PTSD is not controlling them anymore, that they don't have
Mm.
as much of a of that arousal. They don't have it retreats to the back of mind instead of being front of mind for them. So and that's really the elegance of these novel treatments, and that the PRISM and gray matters folks are doing really well.
Are doing. Yeah, thank you.
Yeah.
So you shared with us kind of what the typical treatment time looked like. Is there any information on the cost, sort of bookends that you can share with us?
Yeah, so it does have a code for billing, but it's not,
Oh,
and it's
good.
FDA approved. Uh, the reimbursement will always be a little bit late. We hope that it will be insurance reimbursed in the future, but right now it's not. The cost varies from clinic to clinic, anywhere from a session being, 200 to 300-ish range, but it really just variable. So don't quote me on that because, keep in mind the technology is not as is young. It's not as old as TMS, which is transcranial magnetic stimulation, or ketamine, which is decades old. And so that's still in flux. But it is FDA approved and it's moving forward. Just for context, the transcranial magnetic stimulation got FDA approved in 2009, 2010, I believe. It took like 3 or 4 years for insurance companies to start approving it and actually paying for it. And so that's not uncommon, unfortunately, in the health industrial complex for insurance to lag, which is unfortunate, but it's something that us clinicians expect.
Yeah, and that seems to be the case for so many of these neuroplasticity-based treatments, right? And the neuroplasticians that are out there doing them and developing them. Most of this is out of pocket now because we are at the beginning of that transition, and it reminds me back to what I said in my very opening comment for the summit, is that we are entering a golden age in neurological care. It's really a paradigm shift going from, you've got to learn to live with it to let's treat the root cause of this, not just the symptoms. And I'd love to get your perspective on whether you feel that as well. I mean, you're in the midst of it, right? So your knowledge is so much deeper than mine. Do you agree with that comment that we're entering into a golden age? And if so, where do you see this going in the future? What does it look like five years from now, from a mental health and mood regulation standpoint?
Uh, you're absolutely correct. We are in the middle of a paradigm shift, and I really want the audience and to understand that it truly is a paradigm shift, because there's a pathway for medications, there's a pathway for surgeries. We know what that involves. We know what that looks like. This is neither. Neuroplastic treatments are neither medications nor are they surgical type procedures. So they're completely separate. They're not even in the middle. It's a separate, medications, surgeries, neuroplastic treatments. They're completely separate. And so some of the delay is because the regulating bodies and the technology companies, the FDA, they don't really know how to treat these things. They don't know which bucket to put them in because it's really a bucket in and of itself. But we're moving in that direction. I mean, there's advocates in the general population like yourself. There's advocates within the professional population that are really driving this and to really execute that paradigm shift. Paradigm shifts are kind of weird. I mean, this, like paradigm shifts it's kind of like nothing happens and everything happens, and that's kind of the way that it works, is that you get frustrated with this lack of momentum, and then boom, one thing happens. And from that point on, it's night and day difference. The world is different. And so, and that's what I think will happen with neuroplastic treatments and with neuromodulation treatments, especially for psychiatry, is that you might see a relative lack of momentum for years, and then all of a sudden it changes. That's because the paradigm has shifted. So.
And when I looked at your practice and what you're doing in your practice, you and your entire practice are really on the front edge of integrating all of these innovative therapies. Can you walk us through just maybe some of the other leading edge interventions that you're using there?
Yeah, of course. Integrative psychiatry is our practice. It's the Kentucky Center for Advanced Neuromodulation. There's 4 physicians here. My partner, Randy Schroed, is right under me in the picture. And then we have Dr. Mary Helen Davis and Dr. Robin Stennett in our practice as well. We're bringing on another physician, hopefully by the end of, in the middle of this year. We have therapists in our office as well. And we're essentially we do general psychiatric care as well, but we are really known for our interventional approaches. And we were a clinical trial site for the transcranial magnetic stimulation adolescent depression trial. So my partner was an author on that paper that led to the FDA approval and now insurance coverage for TMS for adolescent depression. We were, I think, one of the first 50 TMS practices in the world. So we started doing TMS within the first year that it was FDA approved. In 2010, 2011 is when we started doing TMS. So our experience with neuromodulation is it's pretty vast, thankfully, and it's really rewarding because we have all the tools in our tool belt to be able to deliver to patients. So we don't find the problem of, if you have a hammer, everything's a nail, because we have all the hammers, we have all the tools. So we really pick the right tool for the right person instead of just trying to make the person fit with the tool that we utilize. So, you have a robust ketamine practice where we do intravenous and intramuscular ketamine, depending on what's appropriate for the patient. We utilize Botox for depression. We use PRISM psychotherapy, medications, and then of course transcranial magnetic stimulation for depression, OCD, and also off-label indications that we're that we've published on that we're kind of known to do. So it's a pretty unique place. It's a lot of fun. It's really rewarding, and I love it.
Good, thank you. And they're in Louisville, Kentucky, just for the audience's sake. I've got time for one more question with Dr. Farooqui. I want to ask you to please take a few minutes and respond to the poll. Let us know how we have done. And Dr. Farooqui, this question I think is fairly easy for you to answer. Oh goodness, where did it just go? Oh, here it is. So we were talking about PTSD, right? This person's question is really, is it effective for anger management as well? Have you seen any results with that?
So I can pontificate if it'll be effective or
Mm,
not, because remember, it's not, that wasn't a measure that we looked at. But anger is kind of complex though, right? So if you think of anger, anger is the first part of anger is the impulsivity of it. So, the second part is the amplitude of it, right? And so there's this different component, and the third part is what is the trigger itself. So is it a small trigger, but then you have an anger response that people might consider to be appropriate? Is it a appropriate trigger for anger, but there's no cognitive control and you just impulsively respond and then regret later about the anger? Or is it all of those things are happening, but then the actual amplitude of the anger is way above and beyond what it needs to be? So depending on what the anger looks like for folks, and this is why it's really important to really have a conversation with your doc or provider about what it is that is driving the anger. If we peel back the curtain, is it because anger is a normal emotion? Everyone feels angry, but if you have anger problems, well, what's the problem? Is it the trigger? Is it the amplitude of the anger? Is it the impulsivity of the anger? And those things can be addressed in different ways. What might work for one of the reasons might not work for others, and the treatment that you need might be one of those three or
mhm.
a combination thereof. But in terms of if the anger is driven by a fight or flight hyperactive amygdala response, by a hyperarousal response, if that is the backbone of the anger problem, then theoretically, PRISM should reduce the hyperactivity and allow so the red cogwheel gets smaller, which by contrast means that the green cogwheel has more room to play. And so you might notice that irritability, that response, that hyperactivity, that hypervigilance gets better. Now, also remember to that question is that hypervigilance, which some people can say irritability, anger, is a PTSD symptom. And we see reduction across the board with PTSD symptoms. So while I can't comment specifically whether anger problems would get better, we know that hypervigilance gets better. And so if that's the driver, if that elevated arousal is the driver of anger, then theoretically that should improve.
Yeah, it's back to that initial conversation that you were talking about how they're all somewhat interconnected.
Yeah,
Yeah,
absolutely. That's what makes
yeah.
this so fun. So.
All right, Dr. Farooqui, thank you for breaking down PRISM and giving us all of the detail on that, and as well as all the perspective for how all of these things work together and fit together, not only with the amygdala and the prefrontal cortex, but how all of the other interventions work together as well. So thank you for that, and I'll see you in Kentucky soon.
Yeah, thank you so much. A pleasure to be here, honor, and please keep doing what you're doing. It's a great job. So.
Thank you. Bye-bye.